So I'm Aileen O'Gorman. I work in a place called Scotland, which is up on the top of the island of Britain, but I'm Irish, so I live also on the little island there. And I was really interested to hear the other speakers. I know, Elizabeth, I worked with the EUDA, but I haven't heard you speak before, so really impressed that the words harm reduction are being used, because in the UK, where I work, harm reduction has become what we call a dirty word. It's not talked about. So policy talks about abstinence, it talks about recovery. I don't know if you're familiar with this term. It has gained a lot of currency, we say, in the drugs field, that recovery. So when I argue, recovery is abstinence, I'm saying, oh, no, it's also harm reduction, but it's not. It is abstinence by another name. So the policies in the UK in particular have been very recovery focused for, I would say, 15 years. And this coincides, because it's all about politics, this coincides with the Great Recession in Western Europe, and also a shift in political parties to the more conservative parties who were not supporters of harm reduction. And then part of that, I argue, is that we have increasing drug deaths. So this is, the map doesn't work so well in black and white, it's in color on the document, but the darker color on the map shows the much higher drug death rates in Europe. So in Ireland, in the UK, in the Scandinavian countries, much higher rates. And then, France, Italy, Central Europe, and then Eastern Europe, the rates are not so high. So in research to come here, I read about the situation in Slovakia and in the Czech Republic. So for example, the drug death rates are 6 per million in the Czech Republic, 5 per million in Slovakia. In Scotland, they are 240 per million. So I have to work out the maths, how many times more that is. Part of the explanation is how we record the deaths. So in Slovakia and the Czech Republic, are all the deaths recorded with the same intensity they are in Scotland? That is one explanation. But there is still an explanation which, as a social scientist, I am interested in, is in inequalities and health inequalities. And a lot of my work now is looking at drug-related deaths and using what we call a social autopsy method to try and understand the lives of people before they died, to try and understand their interaction with the state systems, with treatment systems, with the healthcare systems, with the criminal legal systems, so people spending time in prison, to see, can we understand better what happens to people before they die? And I argue that the drug is a very small part of that. So going back to what you were talking about, addiction and what is it and how do we measure it, and for me it becomes less about the drug, sorry Elizabeth, but less about the drug and more about the social context that people take those drugs in. So my next slide is in health science and social science, this is a very familiar chart, but maybe not to everybody here. So the World Health Organization, good, bad, sometimes very good. So in this term, this is a very old but important illustration of how our health, so everybody in this room, our health is affected by our daily living and working conditions. So our health outcomes are really dependent on these factors out here. So the general socioeconomic factors, the housing we live in, the education we have, the work we do, if we have work, and if we don't, what the state does to support us. So social policies like income protection. So if we don't have a job, will the state provide us with enough money so that we can live? Or housing, if we can't afford housing, will the state provide for us? So in the UK in particular, these issues have become really difficult in the last 15 years. So the income protection is a very, very small amount of money. The housing, there's huge increases in homelessness. And these are countries that were, the UK would have been very proud of being what they call a welfare state, that you had free healthcare, that you had the right to housing. And all of these rights, so you talked about human rights, have been gradually eroded. So people are less entitled to the support of the state now. So it's like going back maybe a century. So these working and living conditions become really important for our health outcomes. And in Scotland, where I live, what we call health inequalities is really large. So the difference in life expectancy, so this is the best measurement we have. Where I live in Glasgow, it's a very divided city. So the west of the city is quite rich, and the east is quite poor. And there is a 20-year difference in life expectancy from living in the east of the city to the west of the city in 2024, in a very wealthy country. So that for us is, where our priorities are. It is not with people who do not benefit from the system. So, social and community networks are also really important. So isolation, marginalization, particularly if you belong to an ethnic group that is not popular in the country you live in. But your individual lifestyle factors are much less important. So this is a big issue for public health, because most public health approaches will focus on changing your behavior as an individual. So stop injecting, stop using methamphetamines, the main drug here, or reduce your use. But in fact, in health outcomes, we know individual behavior is not as important as the rest. So my work, and the challenge of my work, is to see, is this also true for drug use, for drug-related harm? So lots of people use substances. Our speaker talked about that. Lots of different substances. Some are legal, some are illegal. That's another discussion why some, like alcohol, is such an important industry in Scotland, in Ireland, in the Czech Republic, and maybe Slovakia too. So they have huge power, and the discourse is very different for alcohol and other drugs. So for the drugs that are currently illegal in our different countries, is this, those who have higher risks. So not everybody who uses drugs develops a dependency or has high risk, but a certain population of people do, which is very much linked to their social and economic status within the countries they live in. So finally, I forgot to count my time, probably too long. I'll just focus on this, because the most recent studies I've done have looked at young people who died in Scotland from an overdose, and tried to understand, using the social autopsy method, what was happening. And this might seem strange to you, because I was talking earlier with saying, services in Slovakia, we need more. But in Scotland also, there are services, but they don't have enough resources, or they're not the right kind of services. So they're recovery focused, they're not harm reduction focused. They have a lot of what we call conditionality. So it's not a low threshold where you can go in and just be supported. You have to meet certain conditions to be eligible for the service. And this puts a lot of barriers in place for people, and particularly young people at risk. They don't want a service that says you have to be abstinence. A lot of focus on brief intervention, so maybe some people will talk about this later on, about motivating behavioral change, but a real incapacity, and I know today's is a lot of discussion about mental health. And in the UK and in Ireland and in many of Western European countries where I'm more familiar with the services, there is a real difficulty in supporting people who have both a drug dependency and a mental health problem. And it may not be a psychiatric disorder, because I think later on there are discussions about that, but it can be the mental stress and anxiety that young people have that may never be, an ICD disorder, but it is sufficient enough for them to feel totally anxious, that they self-harm, they have overdosed a number of times before the final fatal overdose. So a lot of difficulty in our systems cannot cope with people who have both a drug dependency and a mental health issue. And if we could have one change, that would be the one I would support. I've way over time, but I suppose other issues around hard to reach services. So in the UK, they talk a lot about people who are hard to reach, that they don't come to our services. Why not? It's because the services are not meeting their needs. So the services need to change, not the people looking for the service. A very dysfunctional, what we call a referral system. So if you go to your GP, your doctor, and say, I'm worried about my substance use, can you help? And they send a letter here, they send a letter there, and it's really difficult to get the help that you need. And then a lot of what we call assessment in treatment services. People are assessed all the time. Every time you go in, there's an assessment form to fill out. And they don't get the support. They get the assessment, but maybe not the support. And then finally, there is an issue with the criminal justice system, but the criminal legal system, where people are over-policed and under-protected. So these are the things in rethinking drug policy would be good to focus on. Thank you.